Welcome, thanks for joining us. My name is Dr. Kenworthy. I'm an optometrist at the Arizona College of Optometry.
And I'm Dr. Fintelmann, also faculty at ASCOPT.
And we just want to go over a few post-cataract surgery findings and complications. We're going to look at four major structures, starting with the conjunctiva.
So conjunctiva is always affected by any surgery, any kind of irritation shows up. I'm sure you've seen chalasis. And in surgery, if you place injections just as this medication at the bottom of the eye, this can obviously show up after surgery as well.
And we can see that on a one-day post-op visit, and you're looking at the conjunctiva and see that little white deposit just under the conjunctiva. At a one-day post-cataract surgery, sometimes you might even see what appears to be a little more airy, more bubbly inside.
That is because sometimes in the beginning of the injections there's a little air bubble that tends to get absorbed within a week. So after 1 week you just see the white chalky appearance of triamcinolone that tends to stay there for a few months.
And this is something we hear a lot on one-day post-ops. Even the spouse or the significant other says, "What's in my husband's left eye? What's going on?" And it's just a little deposit of the triamcinolone. And that even sometimes migrates upward just a little bit.
It depends on where it's injected. Subconjunctivally, it can track closer to the limbus, such as here. The closer to the limbus, the higher the chance of a pressure increase after surgery. I'm sure you've seen post-op pressure spikes or pressure spikes from steroid use. Steroid use closer to the trabecular meshwork affects it more.
And in some cases, steroid responder can be a challenge for these patients. This patient's right eye is a steroid responder. Their pressure's 35, and they have that deposit in their left eye. The decision was made not to use that injection because of the known steroid response.
And whenever this happens, it's treatable either with drops. However, these patients need to be on drops for a few months because this is how long the steroid lasts. Or the steroid can be removed. This I can do in clinic, just cutting out that little deposit under the conjunctiva. It closes, no sutures necessary. There is a small subconjunctival hemorrhage which tends to resolve in a few weeks.
Now moving on to the cornea, we see a lot of complications from the cornea at a one-day post-op. First, reminding ourselves of what's happening during surgery with the actual incisions.
Access points are created depending on your surgeon. Here I created 2 side ports and 1 main incision. Some surgeons only use 1 in the non-dominant hand. So again, if you're right-handed, it will be on the left side of the main incision, or if you're left-handed, on the right side.
And normal one-day post-ops, or even at a week or even a month later, we can still see that area where the incision was made. This is just a one-day post-op for this patient.
And the incision tends to be visible for a long time. Early on, there's always edema, and there's always some staining because there's obviously an epithelial defect in that same area, as you saw initially, where the surface and the stroma was injured.
And in some cases, we can actually see the aqueous just slowly flowing out of that wound. This is a one-day cataract post-op with a positive Seidel sign.
And there's a classic Seidel with the yellow turning into blue. If you want a more sensitive Seidel, paint it dark orange and then watch it turn yellow as a tiny bit of aqueous dilutes the fluorescence, dilutes the fluorescein so that it becomes more fluorescent.
What would be the best management if this was seen at a one-day post-op? Seeing this in your chair.
If the pressure is normal and there's a small leak like this one, you can simply observe and recheck in a week. Topical antibiotics are important, or a bandaged contact lens would be helpful as well. The wounds tend to close by themselves, and the surface, this tends to heal within a week.
And even looking at the cornea, some patients are a little disappointed at their vision at a one-day post-op, and much of the time that can be explained by extra amounts of corneal edema.
And that corneal edema tends to be exactly in the pattern of where the phaco energy was used, which is usually exactly in line with the main incision, since the phaco probe goes in that direction.
So the denser the cataract, the more energy needed, the more likelihood of this type of edema happening in the cornea?
Correct.
And then some patients have other pre-existing problems that limit their vision afterwards. This is a patient who says, "Hey, all my friends had cataract surgery. They all saw great a week after surgery. Why am I not seeing well?" And this patient has Fuchs dystrophy, causing this corneal decompensation.
And this can either be edema or truly just the Fuchs itself can affect the posterior layers, meaning decimate and create this irregular pattern that will cause glare and blurry vision even in the absence of edema.
It's almost like the same symptoms they had with a cataract, and they're still experiencing those symptoms. In this particular patient's case, they actually had a DMAC in one of their eyes combined with cataract surgery and had much better results, a much clearer cornea versus the one that did not have an endothelial transplant.
And this is pentacam densitometry. You can see the posterior layer. This is the area of Fuchs, clearly affecting the entrance pupil. And the other eye, a DMAC graft, is seen in that same layer with a much lower densitometry, better vision.
And then there's this very interesting finding which seems to be very elusive and normally just seen at the 1-day post-op. By the 1 week this is gone, but we see this almost what I'll call debris, but I think a better term is snail track sort of a finding.
This has been described optometry literature and ophthalmology literature, and what we believe it to be is simply lens material that's left on the back of the cornea as these little pieces kind of move by, and they highlight the endothelium, and these are usually gone within a week.
And then one other interesting finding at a 1-day post-op can be elevated pressure, and that can be resolved with burping the wound.
And here a small instrument is used, a foreign body spud that just barely fits into that side port that when entered, as you can see here, just opens that wound, releases aqueous. Ideally you want the aqueous in the teens, the pressure with the release, just so you don't get the pressure too low. Any other instruments, sharp instruments, can enter the eye more easily, and if you open the main wound, there's a chance that the iris can come out.
So done very effectively just with that golf spud right outside of that wound, creating that pressure to release the aqueous. Now when looking into the anterior chamber, one area that we see a lot at a 1-day post-op is inflammation, cells in the anterior chamber. Is that always normal? Do we expect to always have cells, do you think?
Always cells and debris. So you can kind of see these things floating in the light stream over here. And that kind of pattern of cells, which are very fine, and debris, which is a little bit bigger and broader, just the minute microscopic cell debris that's still left and lens debris that will be resorbed within a week usually.
So almost always we're expecting to see those cells. I'd be surprised if I didn't see cells. I'd wonder if anybody was even inside the eye to begin with at all. So more examples of a 1-day post-op seeing those cells in the anterior chamber.
And speaking of which, when cataract is not removed, as in, for example, a lens reposition, you oftentimes do not see as much cell.
And then one concerning finding, and I learned once that if you see inferior corneal edema, one thing to be suspicious of is that there might be a fragment of lens stuck in there. This one's obvious to the naked eye at the slit lamp, but that's going to be a challenge for the patient also, just having lens fragments stuck in there.
And especially if the cornea was initially clear and then get only inferior edema, that is most likely a lens fragment because, as you saw beforehand, the edema caused by cataract surgery tends to be in the center of the entrance pupil in line with the incision.
And the final area we want to touch in this short video is the capsule. So this might be a complication that happens a little later than the 1-day, more likely at a month or beyond, where we see that little film, the posterior capsular opacification after cataract surgery.
And it's going to have different patterns. This is more kind of a scarring. You can have some lines in there. The lines can cause some issues similar to a Maddox rod where they create a line through a light that the patient sees. And this tends to form, as Dr. Kenworthy has said, months later, but it can happen early within the first month, or rarely if they have PSC early on, because the PSC, posterior subcapsular cataract, cannot be removed as easily. Thus, even early on, the patient might be symptomatic and need a capsulotomy, which you see on the right side here early on to improve their vision.
Yeah, and that's pretty typically done. YAG laser, it seems to be favorable to do that cruciate, kind of a cross pattern. Is that what you always do, or is there a different pattern used sometimes?
I tend to do this pattern because I know I can make the opening as large as I want. The other pattern that's described is either an O or an omega, where you make a opening and then have a little hinge on the bottom. The reason why I preferred this pattern is less likely to cause a big floater that then falls back, and also less likely for the opening to be too small because it can always make it larger. If you have that O pattern, then this, whatever size you have, is where it's going to be.
This was interesting. Recently saw a 1-day post-op and the student came to me and said, it looks like they have posterior capsular opacification. I thought, is that possible at a 1-day post-op? And I went back and I looked at the surgical video and I wondered maybe this was just something more dense in the posterior capsule, a PSC, and I wonder if you could share your thoughts on that.
I mean, that's what I mentioned before. It's like if you have PSC, there's oftentimes a layer, even though scarring, but the posterior capsule is not, there's no more cataract, but it's scarred down, and that cannot be polished off during the surgery, and thus you oftentimes, in this case especially, see a tiny bit of haze already there, even immediately after surgery, even with all this great care taken to polish things up as much as possible. Here it's visible in the retroillumination.
So this is the day of surgery, and then the very next day, not too surprised to see just that little opacity, and this patient's going to be winding up needing a YAG laser probably sooner rather than later to clarify that vision.
And the capsule is stable, so this can be done early on, even within the first 3 months.
Just a last fun little video. This, you can hear the sound of the YAG laser, and progressively gets just a little bit faster, meaning that pitch is going to go up. But this is the normal speed for a YAG laser starting that process, and then we get a little bit faster.
It's obviously a very dense posterior capsule opacification. Just commenting on my own work.
I just enjoy watching this. Now we're at 3x speed. Getting close here. finishing off 4x speed. And that was a YAG capsulotomy in about 30 seconds, sped up. Thanks so much for your time. We would love it if you would check out some of the other videos that we have also on our own channel, the Arizona College of Optometry, where we post different videos that might be of interest to you.
And we post every week. For now, we're focused on discussion of surgeries, but there will be more teaching general concepts of eye care as well.
Thank you.